Hello everyone, hope you're doing well today. We are delving into chapter 22, which talks about clients with spinal cord injuries, multiple sclerosis, epilepsy, and cerebral palsy. Today we are focusing on spinal cord injuries specifically. In this chapter, you are expected to be able to understand the basic etiology and epidemiology of spinal cord injury, or SCI, multiple sclerosis, epilepsy, and cerebral palsy, be able to recognize the physiological function and health-related impairments caused or exacerbated by each of these maladies, and understand the basic physiological responses to exercise among clients with these disorders compared with others. You should also be able to recognize abnormal physiological responses to exercise in clients with these disorders and take necessary precautions in planning and implementing exercise and physical activity programs for them. Understand the potential functional and health benefits of regular exercise in clients with these disorders as well. Spinal cord injury, or SCI, refers to a damage or trauma to the spinal cord, which can result in a range of physical and functional impairments. The spinal cord is a bundle of nerves that runs from the base of the brain to the lower back. It carries signals between the brain and the rest of the body, allowing for movement, sensation, and bodily functions. Spinal cord injuries can occur due to various causes, including traumatic events like accidents, falls, sports injuries, or acts of violence. Non-traumatic causes such as tumors, infections, or degenerative diseases can also lead to spinal cord damage. The spine, also known as the vertebral column or spinal column, is a complex and vital structure that runs along the back of the body. It serves important functions, including providing support, protecting the spinal cord, allowing for movement, and maintaining the body's posture. The human spine is made up of 33 individual bones called vertebrae, which are stacked on top of each other. These vertebrae are divided into different regions. The cervical spine is the uppermost part of the spine, consisting of 7 vertebrae from C1 to C7. It supports the weight of the head and allows for movement of the neck. The thoracic spine is located in the middle portion of the back and consists of 12 vertebrae, T1 to T12. It connects the cervical spine to the lumbar spine and provides support for the rib cage. The lumbar spine is situated in the lower back and consists of 5 vertebrae, L1 to L5. It bears the majority of the body's weight and allows for bending, lifting, and twisting movements. The sacrum is a triangular shaped bone located at the base of the spine beneath the lumbar vertebra. It's formed by the fusion of 5 sacral vertebrae and connects the spine to the pelvic bones. The coccyx, commonly known as the tailbone, is a small bone at the bottom of the spine. It consists of 3 to 5 fused vertebrae and provides attached points for certain muscles and ligaments. The spine also has natural curves that contribute to its strength and flexibility. These curves are known as the cervical lordosis, where there's a slight inward curve in the neck, thoracic kyphosis, which is a forward curve in the upper back, and lumbar lordosis, which is an inward curve in the lower back, and sacral kyphosis, an outward curve in the sacrum. The spine is composed of not only bones, but also intervertebral discs, ligaments, muscles, and nerves. The intervertebral discs act as shock absorbers between the vertebrae, allowing for movement and flexibility, while the ligaments provide stability and hold the vertebrae together, while muscles surrounding the spine help with movement and posture. Nerves branch out from the spinal cord and exit through small openings between the vertebrae, transmitting signals to and from various parts of the body. Maintaining a healthy spine is important for overall well-being. So good posture, regular exercise, proper lifting techniques, and avoiding excessive strain on the back can help promote spinal health and reduce the risk of spinal injuries and conditions. The severity and effects of a spinal cord injury depend on the location and extent of the damage. In general, SCI is classified into 2 main categories. Complete SCI occurs when there is a total loss of sensory and motor function below the level of injury. It means no signals can pass through the damaged area of the spinal cord. An incomplete SCI, in this case, some sensory and motor function below the level of injury remains. The degree of impairment varies depending on the extent of damage to the spinal cord. Spinal nerves are peripheral nerves that emerge from the spinal cord and carry sensory and motor information between the central nervous system and the rest of the body. There are a total of 31 pairs of spinal nerves in the human body. Each spinal nerve is formed by the fusion of two nerve roots, a dorsal or posterior root and a ventral or anterior root. The dorsal root contains sensory nerve fibers that transmit sensory information from the body to the spinal cord, while the ventral root contains motor nerve fibers that carry motor commands from the spinal cord to the muscles and organs. The spinal nerves are named based on their location along the spinal column and are characterized into 5 regions. Cervical nerves there are 8 pairs of these cervical nerves, C1 to C8, which exit the spinal cord between the vertebra and the neck region. These nerves innervate the muscles, skin, and other structures in the neck, shoulders, arms, and hands. There are 12 pairs of thoracic nerves, T1 to T12, which emerge from the spinal cord in the thoracic or mid-back region. They provide sensory and motor innervation to the chest, upper abdomen, and parts of the back. There are 5 pairs of lumbar nerves, L1 to L5, which exit the small spinal cord in the lumbar or lower back region. They supply nerves to the lower back, buttocks, and legs. There are 5 pairs of sacral nerves from S1 to S5, which emerge from the spinal cord in the sacral region. These nerves innervate the buttocks, lower pelvic region, and the back of the legs. The coccygeal nerve, as there's only one, which exits from the lowest region of the spinal cord, known as the coccygeal region. They provide sensory innervation to the skin around the tailbone. After emerging from the spinal column, the spinal nerves branch out and further divide into smaller nerves called peripheral nerves. These peripheral nerves innervate specific regions of the body, enabling sensory perception and voluntary muscle control. Damage or compression of spinal nerves can result in various neurological symptoms such as pain, numbness, weakness, or loss of sensation in the areas supplied by the affected nerve. Disorders such as herniated discs, spinal stenosis, or trauma to the spine can lead to spinal nerve dysfunction and require medical attention. A dermatome refers to an area of skin that is primarily supplied by a single spinal nerve. Each spinal nerve in the human body corresponds to a specific dermatome, meaning that damage or irritation to a particular spinal nerve can result in sensory changes or symptoms in the corresponding dermatome. The dermatomes are organized in a specific pattern along the body with overlapping regions, and there are 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal dermatome. Here's a general overview of the dermatome distribution. The cervical dermatomes cover the neck, shoulders, and upper back. The thoracic dermatomes cover the chest and upper abdomen, extending to the mid-back region. The lumbar dermatomes cover the lower back, buttocks, hips, and parts of the anterior thigh. The sacral dermatomes cover the posterior thigh, the back of the leg, and the inner aspects of the lower leg and foot. And the coccygeal dermatome covers the small area at the very base of the spine. Dermatomes are clinically significant as they help in diagnosing the location of sensory abnormalities such as pain, tingling, or numbness. They may be associated with nerve damage or disorders affecting the spinal nerves. By assessing the affected dermatome, healthcare professionals can identify the potential level and location of a spinal nerve issue. It's important to note that while dermatomes provide a general guideline, there can be some natural variation between individuals. Additionally, there may be overlap between adjacent dermatomes, making it challenging to pinpoint the exact location of symptoms solely based on dermatomal patterns. Radiculopathy refers to a condition characterized by irritation, compression, or damage to one or more spinal nerve roots. Typically, as they exit the spinal column, it commonly occurs due to conditions affecting the spine, such as herniated disc, spinal stenosis, degenerative disc disease, or spinal trauma. When a spinal nerve root is affected, it can lead to symptoms along the path of the nerve, which may include pain. It's a hallmark symptom of radiculopathy. It often follows a specific pattern called a dermatome, which corresponds to the specific spinal nerve affected. The pain may be sharp, shooting, or electric-like, and can radiate from the spine to the extremities, such as the arms or legs. Numbness and tingling is another sign of radiculopathy. Feels like pins and needles in the area supplied by the affected nerve. These sensations often follow the same pattern as the dermatomal distribution. Weakness or decreased strength in the muscles supplied by the affected nerve root can occur. This weakness may result in difficulty with activities that require fine motor skills or the ability to lift or grasp objects. Radiculopathy can also affect reflexes. For example, diminished or absent reflexes may be observed when testing deep tendon reflexes in the affected limb. The specific symptoms and severity of radiculopathy can vary depending on the location and extent of nerve root involvement. For instance, cervical radiculopathy occurs when there's irritation or compression of nerve roots in the neck region, leading to symptoms in the arms, shoulders, and potentially upper back. Lumbar radiculopathy affects the nerve roots in the lower back, resulting in symptoms that radiate to the buttocks, legs, and feet. The diagnosis of radiculopathy typically involves a thorough physical examination, medical history review, and diagnostic tests such as imaging, MRI or CT scans, or nerve conduction studies. Treatment for radiculopathy aims to alleviate symptoms, reduce inflammation, and address the underlying cause. It can involve a combination of conservative measures such as rest, physical therapy, non-steroidal anti-inflammatory drugs, and epidural steroid injections. In some cases, surgery may be considered if conservative treatments do not provide sufficient relief or if there's evidence of significant nerve compression. Orthostatic hypotension, also known as postural hypotension, is a common autonomic dysfunction that can occur in individuals with spinal cord injury, mainly affecting complete injuries above the neurological level, T6 or thoracic 6. It is a condition characterized by a sudden drop in blood pressure upon assuming an upright position. It typically occurs when a person goes from lying down or sitting to standing, leading to symptoms such as dizziness, lightheadedness, fainting, or blurred vision. In individuals with SCI, orthostatic hypotension may occur due to the disruption of autonomic control over blood pressure regulation. The exact mechanisms underlying orthostatic hypotension and SCI can vary depending on the level and completeness of the injury. Here are some factors that contribute to orthostatic hypotension. SCI can disrupt the sympathetic nervous system, which plays a crucial role in regulating blood vessel constriction and blood pressure. The impaired sympathetic response can result in inadequate vasoconstriction upon assuming an upright position, leading to decreased peripheral resistance and subsequent drop in blood pressure. The loss of muscle tone and function below the level of injury in SCI can reduce the effectiveness of the muscle pump mechanism. Normally, muscle contractions during movement assist in returning blood to the heart. In SCI, the reduced muscle activity and paralysis in the lower extremities limit this mechanism, contributing to orthostatic hypotension. SCI can impair the ability of veins to return blood from the lower extremities to the heart. This leads to decreased venous return and subsequent reduced cardiac output, contributing to a drop in blood pressure upon assuming an upright position. There are fluid shifts within the body upon assuming an upright position that can exacerbate orthostatic hypotension. Individuals with SCI may have altered fluid balance due to impaired sensation and mobility, leading to fluid pooling in the lower extremities and decreased blood volume. Managing orthostatic hypotension in individuals with SCI involve a combination of non-pharmacological and pharmacological approaches. Of course, lifestyle modifications, encouraging slow positional changes such as sitting up or standing up gradually to allow the body to adjust. Avoid sudden postural changes. Adequate hydration is also important. You can also implement techniques to enhance venous return, such as leg exercise, muscle pumping, abdominal compression, or elastic compression garments. These techniques help improve blood flow and alleviate orthostatic hypotension symptoms. And in some cases, medications may be prescribed to manage orthostatic hypotension. These may include alpha agonists, fludrocortisone, midodrine, or other medications that can increase blood pressure or enhance fluid retention. The use of medications should be guided by a healthcare professional experienced in SCI management. Spinal cord injury, or SCI, can lead to a wide range of clinical manifestations, which depends on the location, severity, and extent of the injury. The clinical manifestations of SCI can be categorized into two primary types: sensory or motor impairments. Here are some common clinical manifestations of SCI. SCI can result in a loss of sensation below the level of injury. The loss of sensation may affect touch, temperature, pain, and proprioception, or awareness of body position. Some individuals may experience abnormal sensations such as tingling, burning, or hypersensitivity in the affected areas. The loss or alteration of sensation typically follows a specific pattern based on dermatomes, which are specific regions of the body innervated by different spinal nerves. SCI often leads to paralysis or weakness in the muscles below the level of injury. The extent of paralysis depends on the level and severity of the injury. Paraplegia refers to paralysis or weakness in the lower extremities, while tetraplegia or quadriplegia refers to paralysis or weakness in both the upper and lower extremities. Many individuals with SCI experience muscle spasticity, which involves involuntary muscle contractions and stiffness. Spasticity can affect mobility and may cause muscle spasms or rigidity. Prolonged immobility and decreased muscle use can lead to muscle wasting and atrophy in the affected areas. There are also autonomic dysfunctions that occur as well. SCI can disrupt the autonomic control of blood pressure and heart rate, leading to low blood pressure or orthostatic hypotension that we just talked about, irregular heart rate, and potentially life-threatening cardiovascular complications. Injuries above the level of the phrenic nerve, which controls the diaphragm, can result in respiratory impairment, requiring respiratory support or assistance. SCI can affect bowel and bladder control, leading to urinary and fecal incontinence, urinary retention, or difficulties with bowel movements. SCI often leads to sexual dysfunction, including impaired sexual arousal, erectile dysfunction in males, and altered fertility in women, in both. Some individuals with SCI may experience neuropathic pain, which is characterized by persistent burning or shooting pain in the affected areas. SCI can disrupt the body's ability to regulate body temperature, leading to increased sensitivity to heat or cold. It's important to note that the clinical manifestations can vary widely, again, depending on the individual and the specific characteristics of their SCI. Each person's injury is unique, and the functional outcomes and manifestations can differ significantly. Rehabilitation, medical management, and adaptive strategies play a crucial role in minimizing the impact of SCI and optimizing quality of life. Individuals with SCI are at an increased risk of CVD or cardiovascular disease, as in line with previous evidence. Namely, risk factors for CVD are amplified in individuals with SCI relative to able-bodied individuals. In addition to the immobility caused by SCI, these individuals have unique disadvantages that may further contribute to these risks, relating to the disconnection between autonomic circuits and supraspinal control. As an example, significant liability in blood pressure from extreme hypotension during episodes of orthostatic hypotension to extreme hypertension during episodes of autonomic dysreflexia are typical post-SCI and unique features. Researchers have speculated that this blood pressure instability could result in vascular injury and consequently result in a greater risk for arterial disease in individuals with SCI. Due to the loss of supraspinal sensory input, patients with spinal cord injury may suffer asymptomatic myocardial infarction. Therefore, clinical clues such as ECG changes, cardiac biomarkers, or atypical symptoms might indicate ongoing myocardial injury. ST changes are likely due to alteration in ventricular repolarization in the absence of myocardial ischemia, but somehow mediated by the changes in sympathetic activity due to spinal cord injury. Some patients with spinal cord injury have chronic ST segment changes. For example, ST elevation suggestive of early repolarization. These occur if the spinal cord injury is at a level that disrupts the central control of sympathetic cardiac innervation, leading to altered ventricular repolarization, manifesting as ST elevations. Other clinical manifestations are congestive heart failure, and as we just talked about, pseudomyocardial infarction or abnormal ST wave changes. Sudden death due to asystole and atherosclerosis as it manifests in angina pectoris and myocardial infarction. Autonomic dysreflexia, also known as autonomic hyperreflexia, is a potentially life-threatening condition that can occur in individuals with SCI at or above the T6 level. It is characterized by an excessive and uncontrolled response of the autonomic nervous system to a noxious stimulus below the level of injury. Autonomic dysreflexia is typically triggered by stimuli that would normally be innocuous or minor, but due to the interruption of normal neural pathways between the brain and body below the level of injury, the body overreacts to these stimuli. Common triggers include bowel or bladder distension that can stimulate the autonomic nervous system and trigger autonomic dysreflexia. Infections in the urinary tract, such as UTIs, can act as triggers for autonomic dysreflexia. Skin problems like pressure ulcers, burns, or tight clothing. Any painful or uncomfortable stimulus below the level of injury, such as muscle spasms or ingrown toenails. When autonomic dysreflexia occurs, the body experiences an exaggerated sympathetic nervous system response, leading to a sudden increase in blood pressure. Symptoms and signs of autonomic dysreflexia may include severe hypertension or high blood pressure, where the systolic blood pressure often rises above 200 millimeters per mercury, a throbbing headache. The skin above the level of injury may appear flushed or blotchy, while the skin below the level of injury may be pale. Profuse sweating may occur above the level of injury. A stuffy nose or nasal congestion is a common symptom. The heart rate may slow down. Individuals may feel a sense of anxiety or restlessness. If left untreated, autonomic dysreflexia can lead to serious complications such as stroke, seizures, heart attack, or even death. Immediate medical attention is crucial when autonomic dysreflexia occurs. The management involves identifying and removing the triggering stimulus, if possible. This may include emptying the bladder or rectum, loosening tight clothing, or addressing any skin irritations or injuries. Medications to lower blood pressure may be administered if the blood pressure remains dangerously high. Individuals with a history of autonomic dysreflexia should be educated on recognizing the symptoms and triggers and be prepared to take appropriate actions. Regular monitoring and preventive measures such as maintaining good bladder and bowel care and preventing skin breakdown are essential to minimizing the occurrence of autonomic dysreflexia in individuals with SCI. In the context of enhancing performance in sport, boosting refers to the practice of intentionally inducing an increase in blood pressure through various means, often with the aim of improving athletic performance. This practice is primarily associated with sports that involve wheelchair use, such as wheelchair racing or hand race cycling. Boosting involves deliberately causing physical stress or injury below the level of a spinal cord injury to trigger an autonomic dysreflexia response. This leads to a surge in blood pressure, which some athletes believe can enhance their performance by increasing blood flow and oxygen delivery to muscles. However, it is important to note that boosting is not a safe or recommended response. Autonomic dysreflexia can lead to severe health complications, including stroke, seizures, and heart attack. Additionally, intentionally causing harm to oneself is contrary to ethical principles in sports and healthcare. The International Paralympic Committee, or IPC, and other governing bodies strictly prohibits boosting. Athletes who are found to be engaging in this process may face sanctions, including disqualification and loss of eligibility to compete. It is important to prioritize the health and well-being of athletes and to seek performance enhancements through legal and ethical means, such as proper training, nutrition, recovery strategies, and adherence to anti-doping regulations. When engaging in exercise, individuals with spinal cord injury may be prone to certain types of injuries. Most common exercise-induced injuries for individuals with SCI can vary depending on factors such as the level of injury, completeness of injury, pre-existing conditions, and the specific activities being performed. Here are some of the common exercise-induced injuries. Overuse injuries can occur when repetitive motions of excessive stress is placed on a particular joint, muscle, or tissue. These injuries include tendonitis, bursitis, stress fractures, or muscle strains. Overuse injuries are often a result of improper training techniques, insufficient rest and recovery, or pushing beyond one's current capabilities. Individuals with SCI often rely heavily on their upper extremities for mobility and activities of daily living, which can put excessive stress on the shoulders. Common shoulder injuries include rotator cuff tears, shoulder impingement syndrome, shoulder instability, or labral tears. These injuries can result from repetitive overhead motions, inadequate shoulder strength, or poor biomechanics during wheelchair propulsion or weight-bearing activities. Due to altered sensation and prolonged sitting or pressure on bony prominences, individuals with SCI are at higher risk of developing pressure sores, also known as pressure ulcers. Pressure sores can occur when there is prolonged pressure, friction, or shear on the skin, leading to tissue breakdown and damage. Vigilant skin care, regular position changes, and the use of appropriate sitting and cushioning are crucial in preventing pressure sores. SCI can lead to reduced muscle tone, loss of sensation, and impaired proprioception, which may contribute to joint instability. This can make individuals more susceptible to joint injuries, such as sprains or dislocations, particularly in weight-bearing joints, such as the knees, ankles, or wrists. Autonomic dysreflexia, again, is a potentially life-threatening condition that can be triggered by various stimuli, including stress. It is characterized by a sudden excessive sympathetic nervous system response, resulting in a rapid increase in blood pressure. Individuals with SCI at or above the thoracic level are particularly at risk. Exercise-induced autonomic dysreflexia can occur due to factors such as overexertion, bladder or bowel distension, pressure sores, or clothing or equipment-related issues. To minimize the risk of exercise-induced injuries, it's essential for individuals with SCI to work with healthcare professionals such as physical therapists or exercise specialists who are knowledgeable about SCI management. They can provide guidance on appropriate exercise techniques, gradual progression, proper equipment usage, and strategies to prevent injuries. Additionally, individuals need to listen to their bodies, maintain proper form and technique, and use appropriate protective gear, and seek medical attention if any signs of injury or complications arise. Temperature regulation can be a challenge for individuals with SCI during exercise due to the disruption of autonomic functions. The inability to sweat or regulate body temperature can normally lead to heat intolerance or difficulty dissipating heat. Here are some considerations for temperature regulation and exercise in individuals with SCI. Individuals with SCI may be prone to overheating due to reduced or absent sweating below the level of injury. This can result in elevated body temperature, increased heart rate, and discomfort during exercise. It's important to monitor body temperature during exercise and take appropriate measures to prevent overheating. Adequate hydration is crucial to help regulate body temperature during exercise. Encourage individuals with SCI to drink sufficient fluids before, during, and after exercise. Water is generally the best choice, but for prolonged or intense exercise, electrolyte replenishing drinks may be beneficial. Implement cooling strategies to help manage body temperature during exercise. This can include wearing light, breathable clothing, and using cooling towels or vests, or exercising in a cool environment or with fans. Cooling breaks or rest periods can be incorporated to allow the body to cool down. Consider exercising during cooler parts of the day, such as early morning or evening, to minimize the impact of high ambient temperatures. Adjust the intensity and duration of exercise based on individual tolerance and the environmental conditions. Ensure that the exercise environment is well ventilated and offers adequate air circulation. If exercising outdoors, make sure that you seek shaded areas and use sun protection measures to reduce direct exposure to sunlight. Individuals with SCI should be educated on recognizing signs of overheating, such as excessive sweating above the level of injury, flushed skin, headache, dizziness, or feeling excessively hot. If any of these symptoms occur, it's important that they stop exercising and move to a cooler environment and hydrate. The impact of temperature regulation can vary depending on the level and completeness of the SCI, as well as other factors such as individual fitness level and pre-existing health conditions. It's important to consider these factors when designing exercise programs and to work with the healthcare professionals experienced in SCI management. Individuals with spinal cord injury, venous return may be affected due to changes in muscle function, reduced mobility, and altered autonomic regulation. Here are some considerations specific to venous return in individuals with SCI. SCI often leads to muscle weakness or paralysis below the level of injury, which can affect the efficiency of the skeletal muscle pump. Impaired contraction of leg muscles, for example, can reduce the ability to actively assist venous return. Regular physical activity and exercises targeting the remaining functional muscles, if any, can help maintain muscle tone and improve venous return. Individuals with SCI may experience the orthostatic hypotension or drop in blood pressure that we talked about when assuming an upright position. This can be caused by impaired autonomic regulation, leading to reduced venous tone and inadequate venous return. Strategies to maintain orthostatic hypotension include maintaining proper hydration, using compression stockings or abdominal binders, and performing tilt table exercises under medical supervision. Individuals with SCI may experience neurogenic edema, which is the accumulation of fluid in the extremities due to impaired lymphatic and venous drainage. Proper positioning, regular elevation of the affected limbs, and the use of compression therapy can help manage neurogenic edema and support venous return. Autonomic dysreflexia, a potentially life-threatening condition, can occur. It's characterized by that sympathetic response triggered by certain stimuli below the level of injury, and can lead to a sudden increase in blood pressure and disrupt venous return. Managing that response promptly and effectively is important to ensure proper venous return. Proper use of assistive devices such as wheelchair positioning, seating cushions, or orthosis can help optimize blood flow and venous return in individuals with SCI. These devices should be properly fitted and adjusted to promote proper circulation and minimize the risk of venous status. Individuals with SCI should again work with healthcare professionals that are experienced in SCI management, such as physical therapists, occupational therapists, to develop personalized strategies for optimizing venous return. And regular monitoring of blood pressure and circulation and overall vascular health is important to identify and address any issues promptly. In individuals with SCI, cardiac ischemic pain refers to the pain or discomfort experienced in the chest area due to reduced blood flow to the heart muscle. This can occur as a result of coronary artery disease, a condition characterized by the narrowing or blockage of coronary arteries that supply blood to the heart. Here's some important points to consider. Individuals with SCI may have an increased risk of developing coronary artery disease due to factors such as decreased physical activity, changes in lipid profiles, altered autonomic function, and higher prevalence of cardiovascular risk factors like obesity, diabetes, or hypertension. Cardiac ischemic pain often presents as chest pain or discomfort, commonly known as angina. The pain may feel like pressure, squeezing, heaviness, or tightness in the chest, and it may radiate to the left arm, jaw, neck, or back. Some individuals with SCI may have atypical or less distinct symptoms, such as difficulty breathing, fatigue, or general discomfort. If any such symptom is present, an exercise session should not be started or should be terminated, and medical follow-up should occur as soon as possible. Exercise testing and training for clients with SCI require careful consideration of their unique needs and abilities. Here's some key points to consider when conducting exercise testing and designing training programs for individuals with SCI. Before initiating any exercise program, it's important to conduct a thorough pre-exercise screening. This helps identify any potential contraindications or precautions specific to the individual's SCI overall health and functional abilities. You want to conduct a comprehensive assessment of their individual's baseline function, including their level of SCI, neurological impairment, their strength, endurance, cardiovascular fitness, flexibility, and balance. That assessment helps determine their starting point and provides a basis for tracking progress. The American Spinal Injury Association, or ASIA, classification system is a widely used classification system to assess and categorize the severity of spinal cord injury. It provides a standardized method for describing the neurological level and extent of SCI. The ASIA classification system includes two main components, the neurological level of injury and the sensory and motor function assessment. Here's an overview. The neurological level of injury is determined by identifying the most caudal or lowest intact level of normal sensory and motor function. The neurological level is designated by the corresponding spinal segment, usually reported as the specific vertebra or spinal cord segment, C4, T12, or L3. For example, if a person has intact sensory and motor function at the C6 level, but impaired function at the C7 and below, the neurological level of injury is determined as C7. The ASIA classification uses a standardized assessment called the International Standards for Neurological Classification of Spinal Cord Injury to evaluate sensory and motor function at specific key muscles and dermatomes. Sensory assessment involves testing the ability to feel light touch and pinprick sensations in specific dermatomes or areas of skin innervated by specific spinal nerves. Motor assessment evaluates muscle strength and function in key muscles related to specific myotomes, which are muscle groups innervated by specific spinal nerves. The sensory and motor assessments are scored using a standardized grading scale, ranging from normal, grade 5, to complete absence of grade 0 of sensory or motor function. Based on the neurological level of injury and the sensory and motor function assessment, individuals with SCI are classified into different categories. The ASIA Impairment Scale, or AISA, there's a complete injury with no sensory or motor function below the neurological level of injury. AISB is an incomplete injury with preserved sensory function below the neurological level, but no motor function. C, there's an incomplete injury with preserved sensory and motor function, but more than half of key muscles below the neurological level have a muscle grade less than 3, so fair strength. D, there's incomplete injury with preserved sensory and motor function, and at least half of key muscles below the neurological level have a muscle grade of 3 or more. E is normal sensory and motor function. The ASIA classification system provides valuable information for assessing and communicating the severity and characteristics of spinal cord injury. It helps in predicting potential functional outcomes, guiding treatment decisions, and facilitating research and communication among healthcare professionals working with individuals with SCI. Physical activity and maintaining fitness levels are crucial for individuals with spinal cord injury to promote overall health, prevent secondary complications, and improve quality of life. While SCI presents unique challenges, engaging in regular physical activity and maintaining fitness is still possible. Regular physical activity offers numerous benefits for individuals with SCI, including improved cardiovascular health, muscle and strength, endurance, flexibility, bone density, bowel and bladder function, and mental well-being. It can also help manage body weight, reduce the risk of secondary complications, and enhance independence and functional abilities. Persons with SCI often require adapted physical activity programs tailored to their specific abilities and limitations. These programs may involve wheelchair-based activities, functional electrical stimulation training, aquatic therapy, resistance training, cardiovascular exercise, and flexibility exercises. Working with experienced healthcare professionals and specialized trainers can help develop personalized exercise programs. Engaging in cardiovascular exercises such as wheelchair propulsion, hand cycling, or using adaptive cardio equipment can improve cardiovascular fitness. Interval training, where short bursts of high-intensity activity are alternated with lower intensity periods, can be effective in improving cardiovascular health and maximizing training benefits. Resistance training is essential for maintaining and increasing muscle strength in individuals with SCI. It can involve weightlifting, resistance bands, or functional electrical stimulation assisted exercises. Focus should be on targeting both upper and lower body muscles to maintain balanced strength and functional abilities. Regular stretching exercises are important to maintain flexibility, prevent muscle tightness, and improve range of motion. Stretching routines should target major muscle groups, especially those prone to tightness due to altered muscle function or spasticity. Individuals with SCI should aim to meet the physical activity guidelines recommended for the general population whenever possible. These guidelines typically suggest at least 150 minutes of moderate intensity aerobic activity or 75 minutes of vigorous intensity aerobic activity per week, along with muscle strengthening exercises at least twice a week. It's crucial to consider individual factors such as level and completeness of SCI, their overall health, the status, and any existing medical conditions when designing and engaging in physical activity programs. Regular monitoring of fitness levels, their functional abilities, and any changes in health status is important as well. Adjustments and progression in physical activity programs should be made based on individual goals, abilities, and feedback from their healthcare providers. Overall, regular physical activity and maintaining fitness level is essential for individuals with SCI to optimize health, functional ability, and quality of life. Collaborating with their healthcare professionals, participation in adaptive physical activity programs, and adherence to safety guidelines can help them to achieve their fitness goals while minimizing risks. Cardiovascular fitness training for individuals with SCI can yield significant benefits in terms of cardiovascular health, endurance, and overall well-being. However, the responses to cardiovascular fitness training may vary depending on the level and completeness of the SCI, individual fitness level, and other factors. Here are some general responses to cardiovascular fitness for individuals with SCI. Regular cardiovascular fitness training can lead to improvements with blood cardiovascular health markers such as increased aerobic capacity, improved heart function, and enhanced circulation. It can help strengthen the heart muscle, lower resting heart rate, and improve pressure control, and enhance overall cardiovascular efficiency. It is important to note that in spinal cord injury lesions between T1 and T4, there is a partial loss of the supraspinal sympathetic control of the heart, which is going to result in lower maximal heart rates of between 110 to 130. And maximal stroke volume and cardiac output is decreased due to loss of supraspinal sympathetic control below the level of the injury and the use of only the upper limbs during exercise. You also have smaller active muscle mass, either mostly upper body or likewise, and the muscle's ability to extract oxygen is obviously impaired, especially below the level of injury. This is table 22.2. These are exercise guidelines for people with SCI. I would get to know this chart. It has great information regarding aerobic exercise, your resistance exercise, and flexibility. The motor and sensory functions specific to spinal cord injury vary depending on the level and severity of the injury. This is just an overview of motor and sensory functions associated with the different SCI levels. At cervical SCI C1 through C8, the higher the cervical level of injury, the greater the impact on motor function. Injuries at or above the C4 level may result in limited or no voluntary control of the limbs, including the arms and legs. Individuals with lower cervical injuries of C5 through C8 may retain some level of arm and hand function, allowing for varying degrees of independence and self-care abilities. Sensory impairments are common with cervical SCI. Injuries at or above the C4 level may result in loss of sensation below the neck, while lower cervical injuries of C5 through C8 can lead to impaired sensation in the arms, hands, and possibly parts of the trunk. With thoracic SCI, individuals generally retain good upper limb function. Lower thoracic injuries of T7 through T12 may allow for trunk control and partial abdominal muscle function. However, motor function and voluntary control of the lower limbs are typically affected, leading to varying degrees of paralysis. Sensory impairments below the level of injury are common in thoracic SCI. The extent of sensory loss depends on the specific level of injury. Lower thoracic injuries of T7 and T12 may retain some sensation in their lower limbs. Lower lumbar SCI affects the lower limbs, hips, and some abdominal muscles. So individuals with lumbar SCI typically are going to retain good upper limb function and may have varying degrees of control over the trunk and lower abdominal muscles. Lower limb function is usually impaired, and walking may require assistive devices or braces. Sensory impairments in the lower limbs are common with lumbar SCI, and so the extent of sensory loss, again, is going to depend on the specific level, with higher lumbar injuries of L1 through L2 resulting in more sensory impairment compared to lower lumbar injuries of L3 through L5. Sacral SCI affects the hips, buttocks, and some leg muscles, and so individuals with sacral SCI may retain significant motor function in their lower limbs, allowing for walking with or without assistive devices. However, they may have some muscle weakness and impaired coordination that may be present. The sensory impairments in the lower limbs are generally less severe with sacral SCI, and sensation may be partially or fully preserved in the buttocks, perineal area, and lower limbs. It's important to note that the descriptions are just general guidelines and individual variations can occur. The completeness of the injury, whether it is classified as complete with no sensory or motor function below the level of injury or incomplete with some preserved sensory or motor function, also plays a role in determining the specific motor and sensory impairments. The autonomic functions specific to spinal cord injury vary depending again upon the level and completeness of the injury. Autonomic dysfunctions can be classified based on the segmental level of the spinal cord affected. So with high cervical SCI, C1 through C4, there's a complete loss of autonomic control below the level of injury, impaired respiratory function and potential need for ventilator assistance, loss of sympathetic control over cardiovascular function leading to low blood pressure, bradycardia or slow heart rate, and impaired temperature regulation. They'll have potential loss of sweating and disrupted thermoregulation. With mid to low cervical SCI, C5 to C8, there's variable autonomic dysfunction depending on the level of injury. They may retain some respiratory function, but limited control over coughing and clearance of secretions. They have impaired cardiovascular control, which may manifest as orthostatic hypotension, which is low blood pressure upon standing, and abnormalities in heart rate regulation. Potential impairment in temperature regulation and sweating below the level of injury. With thoracic SCI, T1 through T12, variable autonomic dysfunctions depending on the level of injury. They may retain autonomic control of respiration and have fewer respiratory complications. Cardiovascular dysfunctions may include the orthostatic hypotension and abnormalities in heart rate responses. Sweating and thermoregulation may be impaired below the level of injury. At lumbar and sacral SCI, L1 through S5, they have variable autonomic dysfunctions depending on the level of injury. Generally have better respiratory function with no significant impairment, and cardiovascular dysfunctions may include, again, orthostatic hypotension and abnormal heart rate response. Sweating and thermoregulation may be affected below the level of injury. And bladder and bowel dysfunction, such as neurogenic bladder and neurogenic bowel, are common. It is important to note, again,